Thank you for joining us for today's webinar, Head Trauma and Brain Health, Protecting the Mind for Years to Come. I'm Greg Berry, Assistant Director in the UAB Office of Alumni Affairs. Just a quick note, since we're virtual, don't be surprised if something may be out of place or a technical issue pops up. If you have any audio or video issues, click the reconnect button at the top of your screen, and that will get you back into the webinar room right away. Today, we are taking a deep dive into head trauma and brain health. 30 years ago, we were told to walk it off when we had a head injury and lost consciousness, even if it was just for a second or two. Today, these concussions can lead to issues with cognitive function and mental health in adulthood. Today, we are proud to welcome Dr. Suzanne Judd. Dr. Judd is the director of the Lister Hill Center for Health Policy and a professor in the UAB School of Public Health. She joined the UAB family in 2008 as an associate professor after spending some time as an engineer at Kimberly-Clark. She earned her Master of Public Health and Ph.D. in Biological and Medical Sciences from Emory University. At this time, I would like to officially welcome Dr. Judd. Thank you so much for being here.
Yeah, thank you for having me. It's really great to be with you all today, talking to you about something that we're really just starting to gather data on. And I wanted to take the time in talking to you to talk to you about it the way somebody like me approaches a question like this. Thanks, Greg, for that great introduction. As you all know, I'm an epidemiologist. So that means I'm not a clinician. It means I don't treat people. I don't treat people that have concussions. I don't look for evidence of concussions in people. I look for evidence around what causes concussions, how can we prevent concussions, and then later, how are concussions associated with later brain health. So I wanted to take a step back to level set a little bit so you understand the way an epidemiologist like me approaches a question. What we talk about in epidemiology is this classic exposure-disease relationship, where there's some exposure that we're studying and we're trying to understand how that exposure, that risk factor, whatever you want to call it, how it's associated with an outcome or a disease. In most cases in epidemiology, the relationship's not straightforward, or the association's not straightforward. There are other factors that might actually explain what's going on. The classic example of that in epidemiology was lung cancer. Early on in the 60s, people began studying alcohol and lung cancer and noticed that there was a really strong relationship between alcohol and lung cancer. Initially, people thought that was a causal relationship, and there are factors in heavy alcohol use that can make people more at risk for lung cancer, but the factor they weren't considering early on was smoking. And it turned out people who had heavy alcohol consumption were also likely to be heavy smokers. In that scenario, the heavy smoking is what we call a confounder or a covariate. It means that somehow this variable confounds or explains away the association with the primary factor we're studying. In the case of the example I gave with alcohol was the exposure, lung cancer was the disease, and smoking was that variable that confounded the association between alcohol and lung cancer. Well, today we're here talking about concussion. And why did I give you a quick epidemiology, what we call these diagram, to diagram the problem? It's because concussion can be thought of in one of two ways. In the first half of the talk, we're going to talk about concussion itself as an outcome, concussion as a disease of interest. In the second part of the talk, you'll notice this moves over to the other side of the equation. And we're going to talk about concussion as an exposure, or concussion as a risk factor for other diseases. So it's important that we know when we're talking about data, when we're looking at data, that you know which side of the equation you're on. Are you talking about concussion as a risk factor, or are you talking about concussion as the actual disease itself? And Greg, if you could play this clip, I want to do a little bit of level setting so that people actually know what a concussion is. This clip is from the CDC's website, and it describes what actually happens during a concussion.
A concussion is a type of traumatic brain injury, or TBI, caused by a bump, blow, or jolt to the head, or by a hit to the body that causes your head and brain to move rapidly back and forth. This sudden movement can literally cause the brain to bounce around or twist in the skull, stretching and damaging the brain cells and creating chemical changes in the brain. What you might not know is that these chemical changes make the brain more sensitive to any increased stress or injury until it fully recovers.
That's a great visual. I hope you all got the chance to see that, the actual image. And again, the link is here so you can go back and watch it again. It shows you what's actually happening during a concussion with the brain moving around inside the skull, bouncing off the interior surface of the skull, and in some cases, twisting within the skull. All of those things cause trauma to the brain. And Greg, I love the comment that you mentioned about what we used to think in the 80s and 90s when I was playing sports. You know, people used to say things like, oh, you got your bell rung. Can't remember your name, you got your bell rung. It was very common to blow it off and say, oh, it's no big deal, walk it off, what day of the week it is. You know, you'd get these really silly questions. But never, ever did people consider not playing. As soon as you were done stumbling and you could figure out what general day of the week it was, in my case, you jumped right back on the court and kept playing volleyball. There are many, many sports where that was the case, where the injury to the head was not considered as serious as we now consider it to be today. And toward the end of the talk, we'll talk about why that's changed. But again, having this definition is a good idea so you can get a feel for what the scientists say. Most people in the general public would refer to it as a concussion. We call it traumatic brain injury, or TBI, in the scientific community. So it's slightly different terminology, but they basically mean the same thing. The most important thing with concussion in today's day and age is that people understand the signs and symptoms of concussion, because in a second, we're going to describe how widespread the problem is of concussions. Things that you're generally looking for in your family members and your children, things like headache, that dizziness, if they can't see or have any kind of changes to their vision, any kind of difficulties thinking clearly. That was where the what day of the week it is question came up previously. And then sensitivity they might have to noise or to light. The question really gets at who gets concussions. I think a lot of folks on this call, you may be here and interested because of the fact that in football, we spend so much time talking about concussions. But interestingly enough, the who gets concussions question is not as straightforward as, oh, it's an injury of football players. So again, going back to the primary framework that I would use to study the question, someone like me would say, okay, what are the exposures? What are the predictors for who is going to have a concussion? And if we take a look at the data, these data are old, but one of the things you're going to hear about later in the talk as well is that we don't do enough to collect data related to traumatic brain injury. These data are actually from 1997, and they're only from 14 states. But what these data show very clearly is that males are more likely to have concussions at all ages, all the way up through over the age of 65 than females. The female curves are roughly parallel to the male curves, except in these younger ages. And one of the things we see here in these younger ages, starting at about age 14, all the way through the mid-30s, males are much, much more likely than females to have concussions, to have traumatic brain injury. And then it kind of starts leveling back off, but it doesn't matter what age, that relationship still holds. So this is one of the questions that would be interesting for an epidemiologist. The other thing that I would take a look at as an epidemiologist and find interesting is how the age curves themselves look. So looking at the rate of concussions per 100,000, that's another way to think about it. In epidemiology, we always ask ourselves what the rate is. We don't ask so much what's the total number of concussions. We want to know how many people on a percentage basis or per 100,000, how many people are having concussions. That allows us to look across different age groups and see what's happening. You may be surprised to note that in females, concussions are much more likely over the age of 65 than all other ages of their lifespan. In males, it's roughly equivalent to their risk of having a concussion 15 to 19. Most of you probably got on this call and assumed that concussions really are something that occurs in primarily young people, people playing sports. You might not think about the fact that this is actually a lifelong disease that can occur at any point in time due to trauma from the head or trauma to the head. Another interesting statistic that most people don't realize is that nearly 500,000 kids are treated in ERs every year for traumatic brain injury, which includes concussion. That's a lot. That's a lot of kids every year that are treated for concussion, and these are not all athletes. So this is not something that's limited to kids that play sports. This is from the CDC's website, and it gives you a feeling for how many different types of concussions there are, how many of these people are getting the injuries in their sports. And one of the things that you can see really clearly from this slide is that on an annual basis, sports accounts for very few of the total number of concussions that people have. The primary source of concussions are falls. So that's, as you're thinking about risk factors and things that might happen to your children, to your spouse, to your parents, you have to really be thinking about falls, because falls account for quite a few of the number of concussions each year. I thought another statistic that you might all find interesting and might be surprising to you was the statistic in the upper left-hand figure, looking at just athletes. And again, these numbers are estimated. It's one of the things we'll talk about in a second. How do you get at these data? How would we know what's accurate? If you take a look at it, about 12,000 concussions were estimated to occur in college athletes. Only 4,000 of those were in football players. So again, you probably came into this call thinking football was the primary source of head trauma, but it turns out head trauma in sports is actually more common in sports outside of football when you aggregate all of those sports together. So it's important to look at where these things are happening, what sports they're happening in. One of the more interesting numbers in this figure, if you can see it, is at the very bottom. And again, you can actually pull this up on the CDC website if you're interested. You'll see that women's soccer actually had a higher rate of concussion than football in the years that this study was done, which was 2009 to 2010, and then 2018 to 2019. Women's ice hockey and men's ice hockey were among the highest in terms of concussions, and then wrestling. So that's probably surprising to folks. Another fact that might surprise you is that the bulk of concussions actually occur in service members. So most of the data we have today to study concussions actually comes to us from the Department of Defense, because the military has become very interested in better understanding how service members get concussions when they're in service. Why is there so much focus on football and concussion? And you're probably all asking yourself that question because that's something that has come up quite recently. Well, the reason that we hear more about it with football is actually not because of concussion as an actual exposure, or as an actual outcome, but it's because of concussion as an exposure for a future outcome. And that future outcome that you've probably heard about, you may not have known, that's what they were saying, is this condition of CTE, or chronic traumatic encephalopathy. CTE is a result of repetitive head trauma that occurs over and over again. It causes very specific symptoms in mood and behavior, things like impulse control problems and aggression, violence even, mood swings, depression. It can cause sleep disturbances, which leads to even more anxiety, paranoia. In addition to the mood and behavior symptoms, CTE also is associated with challenges with thinking and memory, which is a lot of the work that I do. I do more work in thinking and memory post-stroke than post-concussion at this point in my career. It also can be associated with impaired judgment, which gets back into the mood and behavior and impulse control, but also dementia and confusion. So because of these new associations that the NFL started to see, concussion became an exposure. And now remember here, this has jumped again. A second ago, I had concussion over on the outcome side, and we were looking at what predicts concussions, what ages, what genders, what sports predict concussion. Now we're saying, okay, concussion is the actual exposure of interest, and it's going on to predict CTE. So this is a slightly different way of looking at this particular question. So what is CTE and what's the timeline of what's been happening? Well, it's actually been around for a long time and was originally described by Dr. Martland when he was looking at boxers. He at the time called it punch drunk syndrome. And it was something that he noticed that boxers that had been boxing for a while seemed to have these behaviors that were fairly predictable. It wasn't until 2005 when Mike Webster died after years with the Steelers. And I put a link to this article from The Atlantic. If you haven't read it, it's a fantastic article that really describes the history of CTE in the NFL and why we are where we are today in terms of studying CTE and the changes that have been made quite recently. But basically, Mike Webster was very interested in what was going on with him. His personal physician was also very interested. And so they took a look at his brain after he died, and they noticed that there were physiologic changes to his brain. So what about CTE? Do we know if there are disparities in CTE? Well, I want to tell you that it's very tough to actually study that question. To answer the question about whether or not there are disparities in a certain disease, you have to have a really large data set to begin to study it. Most of what I do, I mentioned, is stroke. And one of the ways that we can study stroke in the United States is by studying mortality rates. We can look at whether or not there are differences in terms of who dies from a stroke. And again, this is the way that a researcher, an epidemiologist like me starts to look at questions. We don't just say, is concussion associated with CTE? We want to know, is it associated differently in different groups? And again, here you can see that in the Southeast, the mortality rates for stroke are substantially higher than they are for other parts of the country. That's the darker purple that indicates that. We call this region of the country the stroke belt. And again, to think about how this would apply to traumatic brain injury or concussion, I'm going to argue at the end of this that we need to do similar research in CTE and concussion that we would do for stroke or dementia. In terms of stroke and dementia, we're very interested in geographic conditions that may be associated with this increased risk of stroke. And that's because of what I showed you on the previous slide, that Southerners are more likely to die of stroke than other parts of the country. Most people define the stroke belt itself as these 8 southern states that are basically from North Carolina over to Arkansas, then down to Louisiana and back over to South Carolina. So what's the magnitude? This is, again, in epidemiology, we always want to describe the magnitude because that helps us work with policymakers to identify where we should be targeting money to prevent things like CTE, concussion, or stroke. And in this case, the data are much more clear with stroke than they are for CTE and concussion. So it's very easy for me to go out to the CDC website and pull the number of deaths for stroke because it's a condition that we regularly code for in medical records and death certificates. And so we can see that in the US and the stroke belt itself, there are roughly 22,000 deaths in the population. And in the rest of the nation, there are roughly 114,000 deaths per person. We have to calculate that back to a rate. And you'll remember when I showed you the concussion rates for males and females and by age, it was normalized to a rate of per 100,000. That's a very normal number that we use in epidemiology. We like to normalize it to per 100,000 so that we can compare across geographies, ages, genders, race, whatever we're looking at. And the interesting thing with the stroke belt, and probably is true for head trauma as well, that there actually is a difference in rate by geography. We can see that there's actually a 17% higher rate of stroke in the Southeast compared to other parts of the country. That actually accounts for 3,200 extra deaths that don't have to happen. When we think about how many extra strokes that is, because we have to then think about what does that mean in terms of people winding up in the hospital, it actually is associated with about 13,000 extra stroke events. The cost of a stroke is very similar to the cost of CTE. It's expensive. Anything in the brain that winds up needing rehabilitation or extra care following the event, that's just winds up being more expensive for the healthcare system. So you wind up that you can actually come up with costs in terms of the public health burden for any one risk factor. And for stroke, we've been able to show that it's associated, these geographic differences, they're associated with about $1.8 billion in public health burden. Now, similar calculations were done with with CTE, as the NFL was beginning to figure out, well, what are the costs of ignoring the association between concussions and CTE? That's one of the big ways that they can argue for protective mechanisms is by identifying the costs. Interestingly, it's very hard to use those data to then say why something happens. In this case, there are many hypothesized reasons for the stroke belt. You know, why are there differences? Risk factors, case fatality, diet, lifestyle. At the end of the day, as we continue to investigate these various factors that are associated with the differences, we really don't know. We wind up with estimates, but we don't have the actual answer that can say, okay, if we only coded death certificates different, we would see a difference in this association. Well, the same thing is true for race. I think that probably some of you saw on the previous slide that the proportion of African Americans living in the Southeast is one of the proposed mechanisms for the stroke belt. And so the question then becomes, well, how bad is the excess stroke mortality by race? When we take a look at age-adjusted mortality statistics, and again, these are the statistics I hope that we see again someday for CTE and concussions as we continue to collect more data, we can actually look by gender, by race, and by year to look at how these things decrease with time. And hopefully we see a really stark decrease in concussions in the next 10 to 15 years with all of the safety measures that we're starting to put in place in sports. In stroke and heart disease, you can see that both of these have shown decreases in terms of mortality as time has gone on. But what's interesting is that the actual difference between race groups has not declined as rapidly as we would hope. That means that the disparity in terms of who gets a stroke is still a problem, because the black-white relative risk of getting a stroke has actually been increasing with time. So while the total number of strokes is decreasing, we talked about that. On the next slide, you can see that the disparity in terms of the fact that more Black Americans have strokes than white Americans, that disparity is actually widening. And that's one of the things we have to be really careful of in epidemiology. Again, we're very early in the concussion research in trying to understand how these controls that we're putting in place, whether they're actually working. But sometimes what happens in epidemiology is that we make changes and they apply differentially across race, age, sex, geography, whatever it is we're studying. So after we make the changes, we have to go back and make sure that we didn't have an unintended consequence of actually increasing a disparity somewhere. So I've talked to you a lot about stroke, but not about the disparities in CTE. And the question is, why don't we know whether there are disparities in CTE? Well, the reality is it's just very, very new. The dementia research has really advanced in the last 10 years as the NIH, the National Institutes of Health, has really aggressively funded dementia research. And really CTE is a form of dementia. It's a form of dementia in terms of the way that the physical structure in the brain changes. And there's a very interesting article, again, that I linked to that I thought some of you may want to follow up with related to the NFL and related to how the NFL is looking at normative data when they decide who has dementia, following participation in the NFL. And why this should matter for everybody sitting here is that if we look at cognitive function and we think about how we measure changes in cognitive function in particular, what we do is we typically start with people at a younger age and we measure their cognitive function at a younger age. Then we look as they get older to see if their cognitive function declines. And the challenge with CTE is that it's very hard to diagnose without actually having access to the brain itself. And for those of you that have never thought about it, the only way to really get access to the brain is to open up the skull. And that's not something you particularly want to do before you die. There are imaging tests that we can do. There are some biomarkers that we can collect. But at the end of the day, it's still very difficult to diagnose CTE while the person is still living. But one of the ways that they can do that is by looking at cognitive function to see how an individual's cognitive function is changing over time. So these graphs that I've put on this figure, they're actually hypothetical data. They're not real data. I just took 3 random sports of football, volleyball, and squash. And then let's say in theory, you were measuring someone's cognitive function when they were in college and maybe actively playing their sport at age 35 and again at age 65. Well, in this case, the volleyball line is on top. Being the volleyball player, I had the cognitive function of volleyball players the highest. So they start out up at about 12. The squash folks, they start out at about 7, and then the football players start out at about 5 in this hypothetical example. When we checked in with them again at age 35, you can see their cognitive performance is exactly the same as what it was at baseline. But when we checked back in at 65, basically everybody is down at around 2. All sports are down with a cognitive function score of 2. If you don't take into account where the individual person started, you might say, well, everyone's performing at the same level. On the other hand, if you take into account where the person starts, like the volleyball player, and what you're most interested in is the rate of change as it drops from 35 to 65, you might say, oh, wow, volleyball players have it much worse than all other sports because they dropped 10 points in these 30 years. So their change is much bigger. And that's why the NFL initially was actually using race norming. So what researchers do is we try to take the fact that we know the volleyball player started out higher, and we try to create some kind of a normative score that allows us to remove the fact that the volleyball player started out higher. The challenge with that was the NFL was systematically missing a lot of folks when they were looking at brain injury, because over here you can see it's much harder in the football players. The slope is lower, so it's more difficult to actually pick up the people whose cognitive function is changing. This is actually an exciting change for the NFL. It's a change that has rapid implications for even my own field. When we look at dementia research and we question whether or not we should be using race-based norms to study cognitive function. Well, I've complained a lot about the fact that we don't have very good systems to know whether or not there are disparities in CTE. But how could we? What could we do to have better understanding of whether or not disparities exist? And this is the study that I work in, where we are studying dementia, where we are studying stroke. And I would argue that this is a really good way to go if you want to look at changes across the United States in terms of cognitive function and do widespread population monitoring. In our study, we were very interested in the racial and geographic differences I described earlier in stroke. So we wanted to get information on folks' demographics, including income, education, where they live, because neighborhood can influence your brain health, diet. Diet is strongly correlated with brain health and long-term cognitive function. Cardiovascular risk factors like hypertension are also, again, very strongly associated with dementia. We wanted to know whether or not people had access to care and how that influenced their risk for dementia. And we also wanted to be able to do some kind of regular cognitive functioning test with our participants. We wanted to be able to do all of this over the telephone because we wanted to get a sample of folks that were distributed all across the United States so that geography was not a limitation in what we were studying. When you think about that and you think about the way an epidemiology study typically works, what we typically do is there's a field center, say in Birmingham, Alabama, or Atlanta, Georgia, or New York City. And that field center recruits people to come to their study so that they can be studied, so that we can get their blood pressure, we can collect their blood, and then we can look at what their long-term outcomes are. Well, for the regard study, because we were so interested in geography, that model didn't work very well for us. We needed to be able to see people that lived in rural Alabama as well as Birmingham, Alabama. We wanted to meet people from rural Montana, from Chicago, Illinois, all over the United States to try to get a really good picture of these risk factors that might be creating or contributing to disparities in stroke risk. So we decided to contract with a company that some of you may have used in the past, or you may have been into your home in the past. We worked with EMSI, that they've now been bought out by a company named Exam One. But basically their goal is to provide a very brief health assessment for insurance companies, so that if you purchase life insurance for one of your family members to have some survival benefits if something happens to you, the insurance company can check to make sure that you're not likely to die in the next year, is basically what they're checking. So they take your blood, they get your height and weight, they check your blood pressure, and they give a snapshot of how healthy you are in terms of being a good person to insure for life insurance. Well, we use those very same health professionals to go into people's homes and try to get a representative sample from across the United States, so that we could get a really good feel for what some of these differences in brain health might be. In addition to the simple measures like blood pressure and blood collection, we also had the folks that went into our participants' homes collect height and weight and waist circumference. We had them do an ECG so we could look at their heart function. We collected all kinds of blood and urine so we could look at biomarkers of health status, took a look at their current medications, and then also used some questionnaires like diet. You may not think about it. It's actually my primary area of focus within the brain health world is diet and how diet relates to optimum brain health. But you have to ask somebody what they eat, and you have to get them to try to tell you what they've eaten in the past year, how it might be different than other folks. That's actually pretty intensive. It's about an 8-page questionnaire. It takes about 45 minutes. And if you can imagine for yourself, just for a minute, somebody asking you, well, how many servings of apples did you eat over the past year? And is it weekly? Is it monthly? It's just pretty complicated when we start asking folks those questions. But these questions are critical so that we can answer some of the disparity questions I mentioned a second ago. We wanted to follow people for a long time. That's another thing too that's really critical in this type of epidemiology research. Often the primary exposure, like a concussion, occurs when someone is young. Perhaps they had the concussion in high school, they had 3 more in college, and then they got a couple in the NFL. Then they would want to be studied long-term to look for dementia. It may not develop for 30 or 40 years. So you've got to have a method in place to collect data to understand what's actually happening for that person. In our study, we like to collect data every 6 months. We like to just check in with our participants, see how they're doing, if they've had a stroke or a heart attack. We want to know that so that we can look at their medical record. We also want to check their cognitive function. So every year we administer a very simple 6-item screener that really just gets at their basic function. Sometimes this screener is administered in the doctor's office. So some of you may have had something like this before, where they ask you about the day of the week. They ask you about, they'll give you 3 words to remember and see if you can remember those words about 2 or 3 minutes after they told you the words. Then we ask a much more in-depth cognitive screener over the telephone every 2 years. We only do this every 2 years because it's a bit of a burden. Some of these cognitive assessments, I'm not sure if anybody out there has ever had one before, but they're pretty intense. Generally, if you were to go to the doctor and have a full neuropsych battery worked up, it can be anywhere from 2 to 6 hours of questions to fully test your cognitive function. We were looking for something a little more brief than that, about a 20-minute screener, 15, 10 minutes, depending on how cognitively intact the person was. And in this case, we really just ask people, could you tell me how many animals you can name? And then we give them time to name as many animals like giraffe, zebra, as they can name in the time interval. We also ask them how many letter F words they can name to, again, count the number of letter F words that they can name, because that's another good indication of cognitive performance. We give them a word list and we say, okay, I'm going to give you a list of words and tell you what these words are. And I'm going to ask you again in 5 minutes to repeat the words for me. It's a test of their memory to see, how their memory is doing. All of this we can do over the telephone so that we can continue to remotely monitor and work with our participants to look for changes in cognitive function. So what does that result in? That results in what I would hope would be very similar for a study of CTE, if we can ever get one launched and going nationwide, where you could have participants that live all over the United States. They wouldn't have to live near an academic medical center like UAB. They could live far out in rural areas and still be a part of the research, so we could better understand how those concussions are associated with changes in cognitive performance. Here you can see for the Regard study, we were able to recruit 30,000 people that we've been following continuously since 2003. We've been able to do all kinds of research within folks to better understand the way hypertension and diet are associated with dementia and stroke, which again, those very same findings may apply later on as we look at CTE. The one thing I really want to leave you with before I take a look at the chat and answer any questions that you all might have is what type of future directions might we need to see? And again, we really need a longitudinal study of individuals with a history of traumatic brain injury. We don't have anything like this in the country currently. We don't do regular longitudinal follow-up of people after they've had brain trauma, a traumatic brain injury. Sometimes it's found within medical records. In the REGARD study I just mentioned, we actually really wanted to collect data on traumatic brain injury and ask people about concussions so that we could better understand dementia and concussions in our study. But it turns out, because of the fact that the definition of concussion has changed so much over the past 30 years, if you ask somebody who was born in 1920 whether or not they had a traumatic brain injury, first of all, they're not going to know what that word means. But then if you change it and say, how about a concussion? Their concussion may have gone undiagnosed because 20 or 30 years ago, again, you were told to walk it off. So they may not have even known they had a concussion. We also need to have some novel methods related to participant follow-up. We do have small studies, lots of clinics where neurologists are studying their own patients, but we really need to think about other ways we can follow participants that aren't limited to a clinic-based setting so that we can monitor people who live far away from our clinics. The continued implementation of policies in sports will protect our future athletes. But again, as it relates to concussion research, I showed you earlier, athletes aren't the only ones that get concussions. So if we're really going to study the question, we have to take a much more comprehensive look at concussion and how it impacts future brain health. And with that, I'd love to take any questions that folks have, go into detail on any more of the data that we talked about. I'm not sure, Greg, I think I see a chat box.
Yeah, I'll go ahead and monitor those and ask those to you. And some of them are comments that we can kind of phrase into some questions as well.
Sure.
So I'm going to start right at the bottom. Since this person had a head injury, they've had issues with their sleep. They get stressed and irritable much more easily now. And they just kind of lose their composure. It sounds like that frustration of snapping at people is common among people that suffer concussions.
It is common. It's very important to talk to your doctor about. Consider seeing a neurologist. Ask your doctor about the appropriateness of meeting with a neurologist or a neuropsychologist so that you can get the testing you need, just to make sure that everything's okay. The sleep is really important. That sleep, whether you know it or not, that's when your brain heals. That's when your brain can flush out some of the proteins that are not great in terms of dementia and Alzheimer's disease. So getting that sleep taken care of is really important.
Which is very interesting because I remember way back when I was in high school, my brother had a concussion and the goal was to keep him awake and not let him fall asleep. So things have changed definitely over the last 30 years since, we were during those days.
Yep, absolutely.
So somebody's 15-year-old daughter recently suffered a concussion as a result of being dropped during cheerleading. There have been several concussion cases this year with head, neck injury on the squad. The cheer coaches stated that there is an inherent risk for this type of injury in cheer when they voice their opinion or their concerns. Do you have any, best way to kind of approach that situation with the coaches and say, hey, how can we maybe limit these and what can we do going forward?
Yeah, absolutely. I think one of your best friends when you're looking at high school sports is the athletic training department. So talking to the athletic trainers, they're often the most knowledgeable when it comes to concussions. They have whole concussion protocols now for official, trained athletic trainers. The other option is to talk to the athletic leadership within the school outside of the coach. The coach's goal is often getting people back on the field, back on the in the cheer squad, and their goal may not be the health of the athletes, but the school has a vested interest in the health of the athletes. So working through the administration in the school, everybody from the athletic director to the trainers, that's probably your best bet rather than the coaching staff.
And I can just tell you based off experience, I tossed it in the chat a few minutes ago. My daughter suffered a concussion several years ago when she was fielding a ground ball. Took a bad hop, hit her in the noggin, she fell down. It was a long back to, practice protocol that she had, and she did work with the training staff as well as the counselors.
Yep.
And there are certain things that you can do in school as well. So is memory loss from blacking out part of having a concussion as well? When this person was about 8 years old, they ran into a brick wall on the playground. Their head started bleeding. They were sent to the nurse's office. The next thing they know, their parents had driven an hour just to pick her up.
Yeah. Yep. Absolutely. So common in childhood. Like you saw that stat, 500,000 kids wind up with pretty banged up heads. And a lot of us did back in the day. That was pretty common. Those are important things to tell your doctor. Nothing specific that you should be concerned about today, but it's worth telling your doctor to see if your doctor thinks that there's any kind of test that they want to do currently to make sure everything's okay. Again, likely it's fine, but it's worth letting your doctor know.
This person suffers from short-term memory. It's just horrible now. They say they used to be able to get to the grocery store, not need a list. Now they live by calendars, lists, and smart speakers because they forget everything. These issues have caused major problems in their career because they're a college instructor and the memory is vital to the work duties. So
Yeah.
Is there anything they can do?
There are lots of things out there now. There are apps that are designed to help with memory. The University of Cincinnati has one. Lumosity is one that has some apps designed to help with memory. They've actually been clinically proven to help with memory, so you may want to consider something along those lines. There are some dietary recommendations to lower the inflammation in your diet, less sugar, more whole foods, fruits, vegetables, lean meats, that can also help. And then again, definitely talk to your doctor and let your doctor know to make sure. You may want to get a full neuropsych workup to see if there's anything else that can be done.
An attendee suffered multiple concussions playing college football. Some were reported, some weren't. He'd love to meet with anybody interested in exploring concussion reporting behavior in college athletes. Is there any place that he can be hooked up with?
The NCAA is collecting some of that data on their website, but it's not really fully up and running yet. I think CDC and NCAA are working on some kind of a partnership. But again, I would like to see that expanded into some kind of a registry or someplace where you could actually go and document your symptoms and describe what happened, answer some questionnaires. Stay tuned. If I hear of something that's available, I'll certainly send it back through this group for you to email out. But right now, there's really not as much out there as I wish there were.
Fantastic comments and questions still rolling in. Is there anything that this person can do now to try and decrease their risk of dementia as they age?
Yeah, absolutely. Blood pressure control is really key. The brain is very sensitive to changes in blood pressure, so it's really important that you control your blood pressure. The other thing is diet, reducing those saturated fats, increasing your intake of whole grains, fruits, vegetables, the good fats, the fats that come from fish. But you don't have to eat fish to find those fats. You can find them in nuts like walnuts, flaxseed, hemp seed. You can get lots of good fatty acids. The brain loves fatty acids. It's actually its favorite food. So getting really good fatty acids is good for your body, and then lowering that sugar intake.
Does taking Brain Boost help prevent senile dementia?
There are no clinical trials that demonstrate that. So often these supplements, they don't wind up going to clinical trial because it's not the way supplements work. I always tell people though, if it works for you, it works for you. Don't, as long as it's not unsafe, make sure that it's got good safety, that it's made in a safe way, that it's compliant with good manufacturing practices from the Food and Drug Administration. But yeah, I always joke, I take vitamin C every day. There's no clinical evidence that it works, but it makes me feel better. So.
You mentioned your interest in diet and TBI. Do you feel like there are dietary measures to help with healing after TBI?
Absolutely. I think that we don't have the clinical data to know for sure. That's what we like to do in Epi. We'd like to actually have clinical trials that would show the diet before and after. But there are anti-inflammatory things like the fats that I was talking about with nuts. There are also certain antioxidants that have been shown to be incredibly beneficial to the brain. Blueberries in particular contain an antioxidant that's been demonstrated to be very effective in terms of memory in children. So those things that we can see from small clinical trials that work for other brain outcomes, like memory in children, it's logical that they would work for adults as well. But again, we just don't have the clinical trials to say for sure.
What is the typical time progression with a typical traumatic brain injury? Is it more progressive as you get older?
It depends on the nature of the injury and how well it healed. One of the things that I don't know if you saw from the video, but if you get the chance to go back to the CDC's website and watch that again, you'll notice that what they talk about is after the brain itself has been damaged, it's really important to let it heal before you re-damage it, because re-damaging it while it's still healing is particularly problematic. So it really depends on whether the person rests and gets the healing that they need in their brain, or if the brain suffers another injury.
I just dropped that video link in there so people have access to it directly. So is there a difference in the long-term effect of a minor or major concussion, or does it just depend on the individual and things can vary so widely?
Things can vary so widely. It depends on the part of the brain that was injured. It depends on how severe the injury was and how well it was cared for. So it really depends on a lot of different factors.
How can family members help ease the TBI patient transition into life again? And what could we do to help with the healing process? Therapy is certain.
Absolutely. Absolutely. Working with their doctor to figure out what the right type of rehab was for their specific brain injury is key. Making sure the environment's supportive to do that rehabilitation, making sure that there's plenty of good, healthy foods available, so that they're able to eat the things that they need to help their brain heal.
So this person had an emergency, or this person's father had emergency brain surgery from a concussion that he did not know he had had. He had passed out when he hit his head and did not recall the incident. He's old school. It is hard to get him to see a doctor. What are some cognitive exercises that he should be doing to prevent cognitive loss?
Yeah, there's, like I said, there's some apps. There's some great apps. The Lumosity app is one that has had the most attention. You can even just do general memory games. If they're really old school, I picture my grandfather who wouldn't have picked up an app and done any of this stuff. But you can do things like, oh, do you remember the house on Crary Street? Or just going through general memory games with the person. Physical activity, if you can get them up and moving, even if it's just 15 minutes of a short, easy walk, 2 to 3 miles an hour, just moving. That movement and the blood kind of moving a little bit more rapidly as the heart rate increases. It's just really good for the brain. It will help the person sleep better. So any of those things to get them moving, to get them trying to use their memory, thinking back on things. Games where they engage their memory, like the Simple Kids card game where you're trying to remember where the cards are. Any of those things can help. The brain really does need to be exercised.
Well, Dr. Judd, this has been fantastic information. Great comments, great questions that we had come through the chat. Thank you so much for lending your time this afternoon and talking about concussions, talking about dementia, and what we can do to kind of help along the course of the path.
Absolutely. Absolutely. And thank you for letting me come in and talk about it from my epidemiology perspective. It was great to be here.
You are so very welcome. For everybody who did attend today's webinar, recording will be made available tomorrow. Let us take care of your evening on Sunday, November 7th. Join us for our 13th annual Uncork Education. We partnered with Perry Steakhouse to offer regional dining options while welcoming students from the UAB Department of Music for the evening's entertainment. We have something for everyone, ranging from a night of music only to dinner for 6 from Perry Steakhouse. It's a take-home dinner for 6. Find out more at alumni.uab.edu/Uncork. Also, don't miss out on other webinars we have coming up. Next Tuesday, November 2nd, we'll welcome Dr. Jeffrey Wycliffe for From Ashes to Floods, Our Changing Environment, where we will explore current environmental health problems and future directions of the UAB School of Public Health. We'll welcome Robert Smith to our webinars on Thursday, December 9th for an important conversation about grief and the holidays, tips and strategies on how to cope. And before the new year, learn how to wow your family and friends with your cocktail making skills as part of Holiday Mixology 101 with mixologist Ryan Abrams on December 16th. You can check out all of those virtual offerings and register at alumni.uab.edu/ events. If you're looking for a podcast to listen to during your day or on your way to and from work, check out UAB Green and Told. Listen back to episode 54, Concussion Conversation, with Dr. Heath Hale and Dr. Kathy Weiss to learn more about concussions and how it's being approached by the athletic department. Also, Dr. Suzanne Judd, today's guest, will be talking about food right before Thanksgiving as we gear up to really fill ourselves, kind of giving us tips on what we can do. That's going to be later on in November. You can find all of those on Spotify and the Apple Podcast app, or visit alumni.uab.edu/green and told. And stay on top of everything alumni and social media. Search UAB Alumni on Facebook, Instagram, and Twitter. On LinkedIn, search UAB Alumni Career Community. If you want to email us, just go to alumni@uab.edu. Once again, thank you so much for joining us for today's discussion with Suzanne Judd. Have a great afternoon, and as always, go Blazers.